5 years ago, when we held, or 6 years ago, when we held our first conference, we had the good fortune of having John Pepper address the audience. So John Pepper was the CEO of Procter & Gamble for many, many years and ran that multinational, giant, 100,000-person organization. He was actually on the board of trustees at Yale for a period of time, so he was fortunately local and available. He had retired, so he was no longer at Procter & Gamble, and we had the great fortune through some connections with him through actually Mary Bissell, and her father worked with him. Mary, where are you, Mary? So we were able to connect with him. And for me, it was like the, I guess, almost like the Academy Awards in a way, to meet somebody who actually ran a rival company from Kraft at the time, who was a heroine of the industry, who was able to run a gigantic, innovative company in a very sort of staid, regulated environment of food and consumer packaged goods. And it was the first time he spoke, and he talked about something called a burning platform, which was the first time I heard that phrase used in this work. And his description of it stuck with me for, first of all, the image of it is an intense sort of visualization, especially with, probably might not have used that after the Gulf disaster, but it stuck with me in the sense of what really is the key burning issue that an organization needs to stay focused on. That's timely, that's critical, that's motivating, and that really is critical to the future success and innovation. Because we were asking him to speak a lot about how do you motivate 100,000 people in an organization around innovation and change across the globe. And he spoke to that, and the thing that he really concentrated on, this idea of identifying what the burning platform was, focusing the appropriate amount of resources on it, and keeping it top of mind and front and center on the agenda in order to have a galvanizing idea to motivate people. I think that idea of a burning platform is what we have here now with the Affordable Care Act, with the energy and the intensity of the interest and the support from the federal government to really grapple with and address interoperability and the resources that are there today. And the question is, how do we keep that front and center in our minds and take advantage of the opportunity we spoke about a little bit earlier that really is right front and center right now? And so I am so delighted to have our three guests and panelists and colleagues here, if I might say so, to help sort of paint the picture of what it looks like now at the federal level and try to help translate what the opportunities are that are right now and that are emerging, and some of the challenges perhaps that you can see right in front of us right now. And to set the stage really for the conversations that are going to be ensuing from here. Because I think probably for the first time there is such an integrated approach towards addressing this issue. Certainly in the experience I've had, I'm not sure I've seen it before to the degree and the level that's available to us right now. In our preparation, some of our preparatory calls for this meeting in particular, I was impressed and greatly appreciated the concern and the attention and the appreciation of the issue and the opportunity and the desire and the interest to participate in this conference and in presenting today right now. And some of you may have actually seen some of the material that's come out prior around this joint memo that the three organizations plus SOCI has put out to try to begin to communicate this desired sense of we're in this together and we're figuring it out, we're moving forward, and that there is intentionality to looking to find places to connect in new and different and exciting new ways. And so I want to welcome you here. David Hansell, Assistant Secretary from Administration for Children and Families, Jessica Shahin, the Associate Administrator for SNAP, and Penny Thompson, the Deputy Director. I'm not going to read their bios for you. They didn't even ask me not to read their bios, but you have them here. You know them. If you want more details, they're available. So what we'd like to do is we've asked each of them to prepare some comments for us here, and then we'll use the rest of the time for discussion as we go through. So David, would you like to start off here? You can either speak from here or... Perfect. Thank
you. Good morning, everyone. Daniel, thank you very much for bringing us all together for this very important conversation. I'm delighted. This is my second Stewards of Change conference, and really delighted to be back. And particularly so because we have so many of my ACF colleagues here with us today, as you mentioned. Would all the ACF folks raise your hand? Yeah. Please, I was actually joking with a few of them earlier about I'm monitoring closely to make sure that they're being appropriately interoperable and networking with other folks. So I hope you mean it. But the truth, of course, is the challenges to interoperability are often as much internal as external. And so it's also great that they have a chance to get to know each other here as well. But I do hope you'll seek them out, because we are very excited that so many of us could be here for this. And we're excited about what we're going to take back from the conference to ACF. I'm also really honored to be on the panel with Penny and Jessica. They personally and their organizations have been wonderful partners in this work, and so it's great to be here. And I have to acknowledge Rick Friedman as well from CMS, who ought to be up here with us, but we'll certainly be hearing from him over the course of the next couple of days. So we really think of the quest to achieve interoperability as a kind of a peaceful revolution in the way that we do our work at ACF and in the business of doing health and human services. And like any revolution, it's sort of a cause that we're rallying around. You have to kind of rally the troops to make it happen initially. You have to have focused leadership to make it happen. And you have to have a core of committed people who then want to take the mantle and the banner and carry it forward. And it also, like any revolution, there are a lot of barriers that have to be overcome, mostly having to do with the way we've always done things. But I think the reason we're all here is because we all believe that not only is it the right goal for us to achieve, the right revolution for us to be engaged in, but also because, as Daniel just said, the conditions are uniquely right at this point in time for the federal government to partner with state and local government to storm the barricades of old thinking and to really achieve a new way of doing business. And we want to grab that opportunity. We want to grab the opportunity to create an interoperable world in which clients have a more seamless and sensible experience in dealing with us and our programs that leads to a better chance of positive outcomes for them. And so that our agencies, the ones that we actually administer in the governmental level, will also achieve reduced duplication of effort, will save money, which is critical to us also right now, will reach more people in more effective ways, will use data much more efficiently and effectively, and in the end will carry out our mission more effectively and more successfully. So what I want to do today in my remarks are really to talk about three things. One is how we're implementing interoperability at ACF, how we're trying to achieve culture change within a large organization. Then talk some about the opportunities around healthcare reform. I'm not going to step on Penny's toes. I'm just going to talk specifically about the opportunities for health and human services integration. And Penny will talk a lot more about what's happening within the health sphere specifically. And then finally, I want to talk about some of the very concrete things that we've done over the past year and a half, 2 years, to try to support state innovation, because that's ultimately where this is going to happen is the state level. It's not us. We have to get out of the way. It's the states and localities that actually deliver services that will make the difference. And so I want to talk about some of the things that I think we've accomplished to make it easier for states to innovate, and then a couple of the areas where I think we still need to focus our attention. So beginning, let me talk about ACF. And I should say the most important thing probably is to make it a leadership priority from the top level, and I think we've tried to do that. And I have to, of course, give credit to my predecessor, Carmen Nazario. She was the one who really hooked up with Daniel, hooked up with Stewards, and said, this is something we're going to do. This is something we're going to put resources into at ACF, and we're really going to change the culture. And I've certainly tried to carry that on, but she was the one who really made that commitment in the first place. So let me give you a few examples. Some of our programs, we have some examples, I think, of interoperability that have actually come quite far in the last year or year and a half. And let me just give you a couple examples of those. One is what we call our asset initiative. And Jim, where's Jim? Is Jim here? There's Jim in the back. And Jim Getz runs that for us. The asset initiative is an acronym for Assets, Savings, Support, Education, and Training. It's administered within our Office of Community Services, and we think it's a great example of multiple agency collaboration, both inside and outside of ACF. What we've tried to do is target all of the different low-income communities that we serve across many of our programs, all of whom need financial literacy skills, all of whom need asset accumulation support and strategies. And we've tried to bring what the Asset Initiative offers to a range of populations who hadn't previously been connected. So we've connected it to our Head Start program. We've connected it to our child care program. We've connected it to our Native American programs. We're connecting it to our developmental disabilities programs. You know, connections that aren't they're probably obvious once you say them, but that had never been made before, other groups that needed the services but hadn't had access to them. And we're now making those linkages across the very broad portfolio of ACF programs, all of which serve vulnerable populations that need those kinds of services. Another area is our Office of Child Support Enforcement. I know Vicki's going to talk more about this tomorrow in more detail than I will right now. But OCSE, Child Support Enforcement, has been another locus of interoperability at ACF. Child Support Enforcement is working on some of the barriers that states encounter by teaming up, for example, with the Office of Management and Budget, what a concept, to look at how to properly allocate direct and shared costs among human services programs. And I'll come back to that in a minute. OCSE has also been a leader in developing new data standards. I'll come back to that as well. Critical things that are going to have ramifications and benefits far beyond the child support world. And then finally, a third example, our Office of Family Assistance, which administers the TANF program. OFA has been working closely with our natural partners in the Department of Labor and the Employment and Training Administration. They do very much aligned work that we do, but previously we hadn't been working with them. But now we are. We work with them over the past year and a half, 2 years, around the implementation of subsidized employment programs, an initiative that took off like gangbusters last year around most of the states in the country that administered subsidized employment programs for both low-income parents and youth, working very closely with our labor colleagues. And now we're doing the same thing in implementing a part of the Affordable Care Act that's called Health Profession Opportunities Grants, which will train low-income parents for real career possibilities, real career ladders in the healthcare sector. And again, we're doing this by building on a lot of the expertise that rests in the Department of Labor, but making sure that we bring it into the work that we're doing. In order to get interoperability going even in a stronger way, we've asked every office within ACF to develop an interoperability plan, and each one has done that. And the plans that they submitted to us a few months ago were very impressive. They range from intensive efforts covering a range of activities with outside agencies and outside departments, outside of HHS even. They cover, in some cases, reducing regulatory barriers, designing new systems, and then some slightly less ambitious but also important ones that will set the stage for more collaborative outcomes in the future. Every one of the plans that we got from our offices involved more than one agency. At least 15 of them involved agencies outside of ACF and departments outside of HHS, including agriculture, education, energy, HUD, justice, labor, Treasury, IRS, and the White House, a very broad range of federal departments. At least 15 of those plans involved partnering with states or native communities or localities, and at least 9 of them involved addressing changing regulations or removing barriers to service. So we're very excited, and we've given them very defined timeframes. These are 12-month plans. They have to have clear deliverables and intended outcomes, and we're going to monitor them closely, and maybe next year we'll be able to report back on the first year of this process of actually getting the offices to focus very concretely on interoperability plans. Similarly, we're building a repository across ACF of information, of examples, and of opportunities for interoperability that exist both within ACF and with some of our partner agencies like CMS and FNS, as well as partnerships with states and localities. We're similarly committed to interoperability with activities such as educating our own internal ACF workforce on Human Services 2.0, which, as you now have heard and you'll be hearing over the next couple of days, is a consumer-centric approach to serving at-risk children and families, and learning to work cooperatively with other federal and state agencies to share information in appropriate and lawful ways, because we realize we have to infuse that culture and that way of thinking through all levels of the organization. We can't do it without the buy-in of the staff. It really needs to become part of our muscle memory, part of our sort of reflexive way of doing business. And to achieve that, we've created an interoperability team, an interoperability innovation team across ACF. Again, every office within ACF has designated someone for that team. We've tried to get a mix of staff at different levels in the organization. A number of the folks who are here today are members of that new interoperability innovation team. And they just kicked off 3 weeks ago. I was delighted to be at their kickoff. And again, it's a key part of our culture change effort within the organization. And their job will be to come back from events like this one and inspire their fellow staff members with the message and the opportunities that interoperability creates and the principles that we're trying to infuse into the organization. So that gives you a sense of some of the very concrete, as well as some of the broader sort of more culture change activities that we're doing within ACF to really make it a truly interoperable organization. We think we've come a long way, but we still have a long way to go. Now, let me turn to health care reform a little bit. That obviously, we all know how significant a legislative change that was. It was almost a year ago that the President signed the Affordable Care Act. It's a once-in-a-lifetime opportunity, we think, for health and human services agencies to come together and really seize interoperable opportunities. And if there were ever anything that was an action-forcing event for the federal government, for state governments, and for local governments, this is it. So right now, as the state and federal agencies, health agencies, are designing systems to implement health care exchanges, we think it's a moment to think about interoperability with human services programs. The reason for that is probably obvious to most of the people in this room, and that is that no matter how a state exercises its flexibility in organizing and administering the new programs under the Affordable Care Act, many of the people who are or will be eligible for Medicaid, for CHIP, for the new exchanges are also likely to be eligible for human services programs, which we think argues for an all-out effort to align these programs as much as possible in order to enroll clients more effectively and to realize programmatic, technological, and budgetary efficiencies. Now, we've been at this for a while already. The three partners you see up here, ACF, FNS, and CMS, for a long time we've been holding monthly meetings related to state systems development and maintenance. And the focus has always been on trying to align our guidance to states and our directive to states among our respective agencies, so we're giving as much as we can one set of consistent advice and guidance to states. With the advent of health care reform, we've stepped that up. We've now added an additional quarterly session to discuss how to strategically focus our efforts, how to identify procedures or protocols that need to be changed, and how we can help states better serve children and families through both the existing and the new programs under the ACA, and how they can best make meaningful changes to existing systems as they move into the future. Given the urgency of this moment, in November of last year, and this is in your conference materials, both the health and the human services sides of HHS and USDA put out a joint letter to every head of a state human services agency around the country affirming our partnership with states and with the other federal agencies implementing the Affordable Care Act. And what the letter did was it urged that state human services agencies be at the table as states are designing their new Medicaid and their exchange platforms, and that it included a number of attachments as guidance to states. The recommendations, that Secretary Sebelius put out under Section 1561 of the Affordable Care Act, which talks about developing interoperable and secure standards and facilitating electronic enrollment in federal and state health and human services programs. The recommendations that came from this and that were endorsed by the Secretary that came out of a broad-based work group cover things like common data elements, eligibility standards, business rules, data transmission procedures, and privacy policies. And if you put them together, they would go a long way towards creating a system that would allow a consumer to seamlessly access the full range of both health benefits and human services benefits and services programs. We believe that that letter that came out a few months ago signaled our intention to work collaboratively and flexibly with state agencies as they build interoperable systems under the Affordable Care Act. I continue to hear from state human services administrators that the messages that they're getting are sometimes different, that the messages they're getting either from Washington or within their states are that we're actually looking to pull apart health programs under the ACA from human services programs. So I think it's important for us to be clear, and this is, I'm sure, a conversation we'll be having a lot over the next 2.5 days. We certainly understand that states have very ambitious requirements that they have to meet to achieve ACA implementation deadlines, and that these requirements may make it very difficult to focus on broader systems reform in the short term. And we at HHS are very supportive. While we want to support integrated health and human services development at the state level, and we hope that states will look for integrated approaches, we hope at a minimum that they will design open systems that if they can't initially build broad-based systems that integrate health and human services because of cost barriers or ambitious implementation deadlines under the Affordable Care Act, that they'll design open systems that eventually will allow us to reach more broadly and bring more human services programs into the fold within united technology platforms. And third and finally, I want to talk about some of the concrete things that we've done within HHS and ACF that we hope will make it easier for states to address the obstacles that they may encounter in trying to achieve interoperability as they move forward with healthcare exchanges. ACF has undertaken a project to work with states to create what we're calling a human services information architecture. And I want to acknowledge Dave Jenkins. Dave, you are, where are you? Where's Dave? Over here, Dave. Under Dave's leadership and his colleagues in our Office of Information Services, working closely with our colleagues in CMS and elsewhere, I think we made great strides in this already. The project is designed to produce a technology framework and standards that would result in shared components and shared services among state programs. Our expectation is that the design and the alignment will take a couple of years to accomplish, but that once we've achieved the target architecture, we can then create incentives for states to build towards that target architecture. And we've learned a lot from our colleagues in CMS about how to do that. We're active participants in enrollment, eligibility, and verification work groups within HHS that are shaping the technical architecture of interoperability in healthcare reform. For example, HHS and IRS are working together under, again, Section 1561 of ACA to develop a common set of standards for data exchange. And the Office of the National Coordinator for Health IT within HHS has convened a high-level work group to make recommendations on standards and protocols to simplify enrollment in federal and state health and human services programs. We're talking about how to match federal and state data. We're talking about verification. We're talking about reusing eligibility information for multiple programs. We're talking about allowing people to put their eligibility information online. And we're talking about reaching out to notify people when we determine that they're eligible for a program. Now, CMS is doing the heavy lifting on this. We're not. But the human services side is fully engaged in the process and is fully committed to a result that can address common processes. Our goal, as the technical architecture takes shape, is to work with states to incorporate solutions that enable automated state access to eligibility, enrollment, and verification functions. Within ACF, we're in the process of organizing our own role and contribution to this. We expect to have more resources that states can tap into for technical support with questions and strategy development as we begin to move forward in developing the enterprise architecture. And we welcome questions from states and creative solutions, and we want to continue to have dialogue. And we will continue to solicit views, suggestions from states and our other partners in the effort through all the various formats that we have for maintaining that sort of dialogue. I want to really stop and take a minute to acknowledge Penny's leadership in this, because she has chaired several of these work groups around the Exchange Steering Committee and the Eligibility Enrollment Work Group. And those groups have been tackling very complicated issues under Penny's leadership. And she has exercised enormous grace and intelligence and creativity, I'm told by all my folks who have been participating in this, in carrying all of us through these difficult issues and achieving consensus on some of the very important ones. So while we continue to work with CMS and our other partners on the technical components of the Affordable Care Act, we're also beginning to engage in a stronger way with the National Information Exchange Model, the NIEM standard. Two of our ACF programs, the Children's Bureau and, again, Child Support Enforcement, have been active participants in this effort, along with the National Conference of State Courts, to establish a NIEM family services domain for court information exchange between these two ACF programs and the courts. And we're now working to map the information that's exchanged much more broadly among state human services agencies like TANF, SNAP, Child Support, and Child Welfare, to the data elements and the definitions that we've already established in the NIEM Family Services domain. We think this is a critically important effort. So far, we found that many of the data elements are already common across programs. We've identified 158 unique data elements and definitions and have mapped 149 of them to the NEAM data elements we've already established under the COURT project. And our role is to work with the NEAM Governance Committee to broaden the scope of these standards to the new human services domain across all these programs. This is a critical, foundational activity and element in enabling interoperability among human services programs. We've joined with the Department of Homeland Security and the Department of Justice as members of the NEAM Executive Steering Committee. The Office of the National Coordinator on Health Information Technology will serve as the steward of the NEAM Health domain, and ACF will serve as the steward of the NEAM Human Services domain. Beyond setting up the domain governance and operations, the first set of information exchanges that have been targeted are the information packages used in the verification processes under the Affordable Care Act for eligibility and verification. We're also interested in looking at the wealth of human services exchanges under the New York City HHS Connects model that you'll be hearing more about over the next couple of days. We also, last fall, published a final rule under the Advanced Planning Document, the APD process. Most of you probably know that process, the regulations, govern state systems development that want to use Medicaid, child welfare, child support funding, and SNAP funding under USDA to do systems design, systems improvement. And the goal of our final rule that we just published, which is the first time that the APD process has been changed in, I think, 10 years, is to encourage states to bring innovative information technology to fruition by simplifying and streamlining federal requirements for lower risk projects while increasing independent oversight on higher risk projects. We hope the new rules will enable states to move more quickly and more boldly from developing new approaches to actually putting them into operation while also maintaining our responsibility for appropriate stewardship of federal funds that support these projects. We're also working internally on ways to simplify the cost allocation process under the rules established by OMB. We know that because of these rules, it's often simpler to take the easy approach for states and just say, let's just use one funding stream. It's just too complicated to do the allocation across multiple streams. But that's not where we want states to be going. We want to encourage states to look at braiding funding streams where possible to build integrated, interoperable systems. So we are trying to create and provide to states the tools that will enable them to navigate the very complicated cost allocation process more closely. We were just talking about that a little bit earlier. So I've given you a very high-level overview of a broad range of things that are underway at ACF and within HHS. I hope you will not question me on the technological details too much because you've pretty much just exhausted my knowledge of them. I'll turn to Rick if we have to get any more detail about them, or to Dave. But I want to close by saying that I could not be more excited or energized by the potential of interoperability. There are many issues we need to resolve. Confidentiality is a serious one, and cost allocation. Those are probably the two that I think we still have to grapple with if we're going to really make this happen. But that's not surprising. This is a revolution. We're still in the early stages of it, so it's not a surprise that we have some major battles yet to fight. And we intend to continue to work with states and localities to identify those barriers and to surmount them, which is, of course, the reason why we're all here at this conference. I really believe that the core value of interoperability, putting the client at the center of everything that we do, is the ultimate reason why all of us went into public service. And now we've been handed a golden opportunity to change the paradigm, to encourage a culture of innovation, of risk-taking, and one that will have tremendous potential payoff for our clients and for the country. We have a front seat at this very important revolutionary table, and I hope we won't waste the opportunity. Thanks.
Okay, can I just say ditto and we can go from there? David is so inspirational. I think all the states appreciate very much the leadership that David brings. He came from a state. He understands states. He understands local. And now he understands clearly federal. And the way he can pull that all together, I think, is quite inspirational. So I am a bit struck to have to follow that. But I'm going to give it a try by starting first and letting you know that Undersecretary Kevin Concannon, who is usually the partner at the table, with David and Penny since his regrets in not being here, and I told him I would do my best to channel him. If I'm going to do that, then I have to start with the fact that interoperability is so much more than technology. Technology is what enables us to have success with interoperability. Interoperability actually is human. It is us working together as partners. It is us making sure that the client, the person that we're serving, is who we see in everything we do. That's how we get to interoperability. And that human element, I think, is what Kevin would want to start with. The partnerships that all of us have, David spoke so well about how we work together, federal, state, local. They're so important. I think, though, in many ways, for us to have success, we have to see and hear the people we mean to serve. That's how we will be able to pull all of this together. I appreciate the opportunity to be here and be a part of looking ahead to the implementation of the Affordable Care Act. I cannot express my respect enough for Penny and what she has done to try and bring this into a reality that we can all understand. And I will get into that a little bit because some of this stuff, if David says, don't take me down the technology road, well, I can't even get on the platform. But Penny actually makes sense of it. And I look forward to how she's going to be pulling this all together for us, because this is a moment in time that we must not waste. We really must not waste it. FNS is very fortunate. USDA, all of the federal government, HHS, we're all fortunate in that this is all happening at a moment in time when we have great support for working together better. I mean, I come from a state. I come from Texas, and of course Texas only wants the federal government involved at those moments when they want them involved and then let me go, right? Well, now, isn't that most of us? Isn't that true of most of us? Absolutely. Absolutely. But this is such an opportunity for us to get into this notion of vision as it can actually be operationalized. And I think that's one of the things we really want to try and do right now, because, as we all know, government and public sector is very dynamic, and it can change on us, and we can feel like we're heading down a road and, oh my gosh, we just had to take a turn because we have new leadership who sees it differently. But if we can take this moment in time and take interoperability from every level and make it the way we operate, then any changes or turns along the way for our road, this will be our new foundation for that. And so I think that that's really important. FNS has been working on a variety of issues with other federal agencies, and I want to take just a minute to kind of talk about those, because even though they are not healthcare reform, they are representative, I think, of the kinds of things that we have been able to accomplish in the last few years that have been very critical. In other words, I'm saying I think we're on a path. I think we're definitely on a path, and now we're building up some speed. APD reform, my notes here say that I'll talk about this later. I'm not sure I'm going to have to talk about it a whole lot more, because David did a very good job of expressing how we've been working together with HHS to try and improve and get to where that challenge that states have experienced, where this federal agency says this and this federal agency says that, and dadgummit, I have to do this. How do we pull that all together? We've been working really hard to try and make that easier. Will we get to perfection? Well, we're the federal agencies, so I'm not sure we'll get to perfection, but we're working toward it. We've been working on CHIP eligibility, which is allowing a more automatic enrollment of eligible children in CHIP on the basis of information in the case files of other programs such as SNAP. So that can be very important for states. It's particularly good, I think, for states where the eligibility determination of these programs are in different state agencies. Yeah, that's one of the challenges we'll all be facing, too. It's not like all the state agencies are organized the same way. You have your own unique way of being organized. So building something that lets you still have your unique way of operating is important, and I think that this has helped us a lot. Our nutrition programs have been working with HHS, with the Department of Education, and others on the First Lady's Let's Move initiative. That's extremely important for us, and it certainly is going to take a whole lot more than one federal agency or one state agency or even a local community. It's going to take all of us to deal with the issue of obesity, and so we have come to a really good place where we have real good partnerships in that. We're working with HHS and the Treasury on something called the Healthy Food Financing Initiative. This is a really important view of trying to get healthier foods into low-income areas where food choice can include healthier foods. There's that term, food deserts. I think a lot of people are familiar with, and this has great potential for us working with CDC and Treasury and other organizations. We've got the executive order on improper payments. The unique thing about this particular executive order is that it says program integrity is important. We must make sure we reduce improper payments, and at the same time, we must do that while ensuring access to the benefits. A very critical new message in that executive order. There's the Partnership Fund for Program Integrity and Innovation. There are federal agencies, HHS, USDA, Treasury, Social Security Administration, Department of Labor, Housing, all of these various federal agencies working together to look toward providing grants to states for innovative approaches for integrity and access. $38 million to provide. $38 million sounds like a lot of money until you really start trying to look at how you're going to fund some of these wonderful ideas. So it's really seed money. But it's a great opportunity, and it's really been an interesting way to work across some federal agencies and then develop a collaborative forum that has state and local folks pushing the ideas up to the federal steering committee, so you've got that kind of organic approach to it. The prisoner reentry program is an interesting one. We're working with 16 different federal agencies to look at how we can help people exiting institutions and make them successful as they come out. SNAP, quite frankly, which is my program that I'm most deep in my heart, can be a real challenge for folks because we don't let you apply when you're in the institution. You have to wait till you get out. Okay, now you're already unconnected from. Yeah, how are you going to get there? This is a real opportunity for us to look at ways and maybe even provide some waivers to improve access and get people in a better place once they exit. We've been working with Homeland Security, the U.S. Citizenship and Immigration Services on issues around immigrant policy. Been working with HHS on that as well so that we can raise awareness about benefits and when public charge affects immigration status and when it doesn't. So those are kind of just a few examples. HHS specifically, we've got a few others, working with them on the Medicare extra help population. That's been a really important one for trying to connect with the SNAP benefits. Promoting the TANF ARA dollars for use in our summer feeding programs. That's been really important for us. That's such a gap that we have, and we believe it can make a big difference. And really, that was a great communication effort, I think, between our organizations. FNS and CMS have been working on a joint application. We're vetting some drafts with some states to see how that might work and how we might turn that into an online application. That might be a really good thing when we start getting into some of the other stuff. You know, one of the low-hanging fruit that we see as well that we're working with CMS on is that we understand probably as many as 4 million people getting SNAP that are not currently receiving Medicaid, but they will become eligible in 2014. You know, making sure that we are able to do that seamlessly. Wouldn't that be a wonderful effort? As we go through all of this and we think of interoperability, we know that we can only succeed if we have built common ground across the programs, all the way from the eligibilities workers desk to the state CIO's office to the federal rules and regulations. Well, I got to tell you, that almost makes my heart stop when I think of what all that means. But it is our moment, so that's what we need to be working toward. In the last year, FNS has drafted proposed regulations that are currently in the clearance process that codify and clarify some requirements that were in the last Farm Bill that are related to the testing of state systems. And we've used that opportunity to simplify and clean up some of those existing regulations related to the APD process. So that's going to be very important. We have worked very closely with HHS to make sure, with the rules and regulations coming out there and the ones that we're working on, that we have some synergy there. David mentioned Rick Friedman, who I have the utmost respect for and have enjoyed working with him over the years. I would like to also point out a couple of people from FNS here that I have the utmost respect for and who work regularly with Rick to make sure that we're doing things together. And that is Neva Terry, who is our director of our state systems office, and Karen Painter-Jacquez. And they make sure that those of us who don't understand how the technology can, in fact, empower and enable us, they make sure that if we can't understand it, that we'll at least listen to them and let go. Okay? Don't get these policy people in the way. You know, I have got page after page after page of examples here of the work that has been done that move us in the direction that we need to go, whether it is the cost allocation methodology toolkit that supports states, the work group that we've put together with states, the call center technical assistance group. We had thought that we would start working with states to maybe come up with some standards. States were so excited by this, they wanted to move it into a whole new and broader direction, and so we went right down the path with them. Because call centers can make a great access point and also improve integrity. And so I would just say to those of you in the audience that are state and local agencies, we need to talk to each other at the federal level, but just as important, we need to listen to you because you're really more creative than we are. You're really, really good at this. And I think that opening up those lines of communication and having us all at the same place, hearing what you have to say at a conference like this is really, really important. So I'm going to keep on pushing forward here a little bit because I'm kind of excited to get to the question and answer point because I think question and answers very often help us understand better and even more importantly, give us a chance to actually hear suggestions and information. We are doing what we call modernization in SNAP. I'm kind of wondering if modernization is interoperability. We may have a new word. We've been looking for a different word, and maybe we've got it. We have been working with states move towards more paperless processes, their administrative processes, making some choices that make it a little less burdensome, not only for the client, but for the state agency. Applications being put online has been huge. We have established what we call Modernization Central on our partner website, and it's a library of various pieces of information, resources, policy, technology, business processes that support modernization. We have on there as well a workload matrix that looks at what can you do, whether it is policy, technology, administrative processes, whatever it might be, ideas, how much they cost. Now, not exactly how much they cost because it depends on the place, but is this a high-cost item? Is this a low-cost item? And who has done it? What state has actually done that activity so that you have a contact to go and talk to about what they experienced and how it worked? In the end, interoperability does have to be more than technology. It has to be customer service, the best that we can do for the people that we're serving as the ultimate goal. Just in SNAP, we're serving 1 in 7 Americans right now. If we think of the nutrition programs as a whole, it's 1 in 4 people. If you put that together with what you guys are doing, a lot of people in this country count on what is done in the health and human services programs. And the truth is, there's so much more than that. We have to start thinking about our families, whether it is a family of 1 or a family of 10 or whatever that family might be. How can we holistically approach their needs? I had somebody tell me, it was last night or today, I think it was today. I wish I could find her. She was saying, what the difference does it make to a family what any program is called? Does it matter to them that it's TANF or food stamps or SNAP? What they know is what they need. And somehow we have to get to a place that when they are approaching us, they are getting what they need. And it doesn't matter what the name of it is. It doesn't matter which state agency has administrative authority over that. It doesn't matter which federal agency, because that doesn't matter to them. They just need to take care of their family, whether it's their shelter, their health, healthy food on the table, whatever it is. And that's why what Penny's going to talk about is so remarkable to me. Has everybody in here heard the word the cloud? Right? Does anybody know what the heck it is? I mean, I was just clueless. I would have it described to me, and I'd go, well, you mean the internet? And they'd say, well, yeah, kind of, but not exactly. Well, finally, Penny Thompson told me what the cloud was. And I will say, I am still a pretty dim light in terms of porches when it comes to the cloud. But my light is getting brighter, thanks to Penny. And I am starting to understand that as long as we don't say that everything has to be up here, but that those key components are up here, and they are connected to the various places that people need. And then all of that can come back up to the cloud, so the person or the family that needs it doesn't know about any of those little places it went to go and grab information. They just are in the cloud. That's our challenge, but that is something we can do, and Penny has convinced me we can. So I'm going to turn it over to Penny now, and thank you all for your attention.
So I just want to do a time check. Are we hard stop at noon? So I'm just trying to allow some time for questions, too. Okay. So these guys are great, and I really enjoy working with them. And thank you so much for the kind words. I appreciate it very much. So what is this health reform business? What is that all about? I kind of think about this as there was a time in which, interoperability was something that was nice to do. It was helpful. It made things work a little bit more efficiently for people. It created some business value. It was essentially a compensation for the fact that systems had been built in silos by organizations who controlled all of the assets, and was really focused on this question of moving data from one place to another so that it could be reused. I want to completely associate myself with what Jessica said about the fact that interoperability is as much about people as it is about technology. The technology actually is one of the easier parts of achieving interoperability. And that kind of model of it's nice to do, and we can kind of figure out a way to take these old legacy systems and layer stuff on top and in between that makes them talk to each other in the right way. Health reform assumes interoperability. Health reform is built on the idea that it exists and it works and it's functioning and it's efficient. I'm going to talk about eligibility a little bit, but I also want to point out that the provisions in health reform that talk about payment and service delivery and changing the way health care is delivered in this country and how it's organized in terms of new entities or approaches like accountable care organizations or health homes, that's all dependent on the idea that data around patients moves and is available at a point in care in a coordinated fashion. All of the work that we've been doing around health information exchanges, I have to say it's a reflection on our poor imaginations that we have the same acronyms for different things. May I say, could we have come up with a different acronym or label for health insurance exchanges that did not involve two different kinds of HIEs, health information exchanges and health insurance exchanges? So just always be sure, it's sort of like the cat in the hat thing 1 and thing 2, that when you reference the HIEs that you always classify which HIE you're talking about. But our investments in health information exchanges are all about the idea that information that has clinical relevance to the delivery of health care resides outside of the place and location and time at which that patient may present with a need. And there has to be a way to access, with all the appropriate controls and authentication services, the information that is necessary in order to deliver the right kinds of care to that patient based upon previous care delivered, previous tests delivered and received, and so forth. Similarly, when we talk about accountable care organizations and health homes, it's really an extension of that concept, that there needs to be a point of care coordination where people can come and have a view of themselves with their health care provider that is holistic. And that reflects not just what that health care provider happened to provide the last time they were there, but really the health care experience that they have had, regardless of where they sought to receive that care. The program integrity provisions in health reform also assume a great deal of interoperability of systems and data and move us in the direction, for example, of trying to improve the way that we do something like provider enrollment. And actually the way that which we screen healthcare providers to participate in Medicare, Medicaid, and CHIP, and the way in which we, among those programs, share that information about those providers. To the greater benefit of the program and to the reduction in administrative expense and burden of providers who don't have to supply the same information over and over again to multiple states and multiple state health programs and multiple federal and state agencies. Now, of course, one of the big parts of health reform is this coverage expansion that happens within Medicaid and CHIP, and this new availability of health insurance coverages through exchanges, health insurance exchanges. So for those of you who haven't made a great study of the Affordable Care Act, I'll just sort of skip to the end. Let's imagine it's 2014. I like to do this sometimes when I start to get a little nervous about how much we have to accomplish. It's 2014. This is your experience. It's a Zen kind of thing that you just do. Step back, it's 2014. This is how wonderful it's going to be. You need health insurance coverage. You have a place to go to say, I need health insurance coverage. That place is your choice. You can show up someplace physically. You can use the U.S. mail. You can fax a form. Or you can go online. But the vast majority of you who are looking for health insurance coverage will go online. Because why wouldn't you do that? It's easy, it's accessible, it's simple, it's available. And you might go online directly from your home. You might go online directly from the library. You might go online from, with the assistance of a community organization. But you'll essentially go to an online portal and say, I need health insurance coverage. And in a simple, streamlined, standardized way that will not vary substantially, state to state to state, you will fill out a few things about yourself. So it will say, and this, by the way, will have been tested in terms of user experience and human factors research so that your experience of this online application will resonate with you regardless of your language, regardless of your education level, regardless of any ability levels. It will already take into account and reflect an understanding about you as a person in terms of how you relate to this, this online interaction. You will supply some information about yourself. It will not take long for you to do this. I'll throw out a number, just so we can have an idea about the, where we're at in terms of a ballpark. Let's say 15 minutes. Does that sound familiar? We have commercials now that tell us 15 minutes on an online form will save us hundreds of dollars. That's kind of a standard consumer retail experience, right? How long am I willing to stay online and fill out a form before I abandon it and decide that I'm not interested in it anymore, this is too hard, or I don't know how to make heads or tails of this? So 15 minutes. That information is then received inside of an engine. And maybe it says to you, hang on, wait a few minutes, don't close the screen. And there are a set of verifications that happen around some of the data that you've supplied. And that happens in real time. And that core information that is verified is then returned. And let's suppose there's a match between what you've supplied and the core information that's been verified, according to a set of agreed-upon algorithms. And on a basis of that return, you receive your next step. Congratulations, we have made a determination. You are now about to be enrolled in Medicaid. Your children are now about to be enrolled in CHIP. Or we have now determined that you're eligible for premium tax credit subsidies through the exchange. There may then be another set of questions that are asked of you that say, well, now this is based on the information that you've given us and what we've found out about you through our verification processes. But there might be a few cases or conditions that might cause us to need to do some additional work for you to make sure that you're properly in the right program. So, for example, think about people whose eligibility is determined on the basis of disability, who want a disability determination so that they can be in the Medicaid program and have access to that set of benefits. So there might be a set of screening questions that ask you about that. And on the basis of that, then either a referral potentially to the Medicaid agency for further work, or an enrollment into an exchange plan or to Medicaid or CHIP based upon the information that's supplied. So when we think about that kind of an experience that we're trying to drive to people in 2014, it is automated, it's streamlined, it has built-in authentication and security, it has built-in verification capability. The business rules, which define that decision tree that says you're either Medicaid, CHIP, or the exchange, are vastly simplified from today's Medicaid, especially, eligibility rules, and are a coordinated set of rules that basically say the decision about where you belong is largely based on the same data and the same decision trees. Think about it as, in 2014, we'll have, according to CBO, around 32 million more people receiving insurance coverage than they do today as a result of these expansions. About 16 million will be served through Medicaid, and about 16 million will be served through the exchange. For the most part, the decision about which program, Medicaid or the exchange, is going to be based simply on an income level determination across the country. Below 133% of federal poverty, you're in Medicaid as an adult. Above and up to 400%, you're receiving premium tax subsidies through the exchange. A little bit of variation for kids based upon state programs, but that has a certain boundary as well. So largely looking at an income standard, not looking at assets, not looking at disregards or other resources, based on income, standardized across the country, same rules, Medicaid, CHIP, exchange. For the most part, it's never exactly all in, simple, right? But for the most part, that's the way that it works. So what does it mean to drive to that level of change? I mean, let's really think about how much of a change we're talking about here. Okay, we're talking about one, I mean, the exchanges don't exist now. Let's just talk about it in terms of just Medicaid and CHIP, okay? Largely, people do not get eligibility determined online, right? So we're talking about, if we thought about this like, you know, sitting in a business perspective, you're at Kraft. You're trying to move a customer base that is maybe, what would you guess, 5% online, if that, to 90% online in 3 years. You're trying to drive a determination process that has been generally viewed as successful if it occurs within 45 days to a determination process in which 90% of the cases you want determined in 15 minutes or 24 hours, let's say, to allow for some verification lag. That's a huge delta. We talk about change. When we talk about systems, culture, business expectations, how we define success in terms of getting people enrolled into a program. the opportunity then, as you think about the title of this session, what is Leveraging Health Reform and Other Federal Efforts. So to think about for human services, what does it mean for human services? Let's suppose that on the health side, we're really able to create this change. And the Act specifies that you can come look for and receive health insurance coverage in an experience that is streamlined and simplified, and an experience which allows you to ensure that you're determined eligible for any health care subsidy program in the state, which includes the exchanges and premium tax credits, as well as Medicaid CHIP, or a new alternative program that states can include called Basic Health. So what does it mean for the human services side of the equation to be connecting with Medicaid CHIP and the exchange in that world? Where does the human services side take advantage of this change? So David said, we are committed to trying to make sure that we are leveraging as much of this investment and these assets as possible to the greater benefit of the populations we serve, as well as the fact as it's cheaper, right? We're not just thinking about this in terms of the horizontal with health and human services. We're thinking about the fact that, for example, we know that we can't drive this amount of change in the Medicaid and CHIP worlds without a great degree of leverage, without a great degree of collaboration among states and between states and the federal government about how to go about creating and driving this change. States consistently said to us at the point in time that the Affordable Care Act was passed, look, don't leave us out here on our own. Find a way to organize us and bring us together. We don't want to be inventing the wheel over and over again, and we don't want to have to figure out something that somebody else has already figured out. So one of the things that we're doing is creating a highly collaborative, iterative environment for the development of new technologies, in which we expect to drive and support states in an activity in which they are doing a great deal of sharing of assets and services. This is where the cloud creates all kinds of potential. We've created some grants for states who are early innovators around the technology needs for the exchanges, Medicaid, and CHIP. We've told them that part of this activity is a very high degree of collaboration and cooperation, in which they expose and transfer assets and investments from one state to another, in which we want states to join up with other states and work as multi-state collaboratives in developing some of these basic assets and technologies. And when we think about extending this to the human services side, it's not something that we can each do alone. It's something that we need to be working on as an enterprise in a highly collaborative spirit. So when Jessica says interoperability is as much about the people, to me it's really interoperability is one affect that occurs when you collaborate. We don't have a lot of time to drive the change that we need. We don't have unlimited funds at the federal or state level. We need to be as efficient as possible. And so we really need to find ways in which we can participate in asynchronous development, in which a state that has figured out how to develop a portal can share that portal with other states and transfer that asset across the nation, in which a state that's figured out a big business rules engine can share that with other states, so that we can really create a set of national assets that are available across the country for reuse and sharing, not only to achieve the vision that we just described for 2014, but a whole host of other possible services and program supports. Because if you think about and decompose what's inside of all of that vision of 2014, and you start to think, I've got a portal, I've got a business rules engine, I've got identity management services, I've got verification services. There's all sorts of assets that make up that vision of 2014 that can be of use, not just to accomplishing this healthcare coverage vision of 2014, but can be of use to a variety of different other citizen services that people seek and wish to receive. So just at the time. So I do want to just make a couple of just observations about it. It is a year after passage of the Affordable Care Act, so sort of how is this all going and how is it coming together and what are the challenges? I think the issue about the idea that we have a little bit of a gap sometimes in terms of thinking about business process is right on. So we have lots of people who think really hard about policy, right, in terms of writing regulations and interpreting statutory language in terms of saying, so this is how the policy works. So if you think about something like eligibility, this is how you're going to deal with this particular population, this particular circumstance, et cetera. And then we have a lot of people that hand out money for systems. But in between, there is this question of what is an optimal business process? Because the optimal business process is that which makes the policy work and drives the architecture and the design of the underlying technology. And so we've spent a lot of time doing things like concept of operations and business process modeling and blueprinting around the world of 2014 to try to say, okay, if our policies were here, what would that look like in terms of an actual customer experience? And I think a lot of those kinds of documents and artifacts will become more and more available to the community at large for additional validation and reaction. Because I think that we need to all be looking at this question of what does it really look like from the point of view of a consumer? I enter the system how? What if I come in this door? What if I come in that door? What happens then? How long does it take? What is the definition of success at the end of that process? What will I receive? What can I depend on? So getting people to focus on that business process is really getting them to focus, I think, on the key ingredient to reality, to the real life experience of people. The second thing is really changing the way that we think about change, and this is something that I've just become really keenly aware of in the last year, which is that change requires constant reiteration. It's like a rubber band. There's a natural state to things. And if you don't keep the tension, it wants to jump back to the way that it knows how to do things. And so we're talking about changing the way that we do business, the way we've done business for decades, in very dramatic fashions. And so you can get everybody in the room and everybody go, okay, I got it, I'm with you, that's what we're doing. And then they go to the next meeting, and it kind of fades. And, there's an immediate problem about today's world or tomorrow's world, and people start to revert to the known, to the understood, to the familiar. So keeping the tension on the change and really continuing to demand, well, that's not going to work, because if that works that way, then this can't be a 15-minute experience. So you got to go back. And to always ask ourselves to get to that result that we're trying to drive to for that consumer, for that person. And then really how we think about the opportunity. Everybody has talked about it's an opportunity, and it really is. It's an opportunity for us to really reimagine how we're delivering services. It's an opportunity for us to really change the way that people experience government. It's a really different change when we think about ensuring that people are actually coming into the system of health coverage efficiently and seamlessly. But it really is not going to happen if we continue to work on technology investments in the way that we have in the past. So we really have to think about the way that we think about technology, define technology, purchase technology, and deploy technology. We are used to living in a world in which we start a new eligibility system design, and by the time that it's done, it's 10 years later. Okay, so it's 2011. 2014 is not 10 years from now, right? So we cannot do what we have done before and think that we are going to accomplish that huge delta of change that we just described by 2014. So it means that we've got to think differently about light technologies. We've got to think differently about increasing competitiveness in the marketplace. It means looking towards the cloud and to shared services and technologies as a way to get the efficiency and avoid everybody having to reinvent the wheel and reprocure and redeploy. It really means changing the way that we collaborate federal to state, state to state. and with the private industry, who really needs to be a part of this and who can really help stand up the solutions that we're looking for and need, if we also unleash them from some of the constraints that we've placed on them in the past. And then we need to dramatically, having made this dramatic change and created this new dynamic, we need to get as much leverage as we can out of it. We need to squeeze every bit of business value that we can get out of that. And so to the extent that we can reuse and leverage those assets and services and technologies to the benefit of other programs and activities, that's what we need to do. That will help us sustain those new assets, and it will help us ensure that our total cost of ownership in terms of the entire programmatic view goes down. So I'll just leave this. Right now, 2014, 3 years away, a lot of money on the table, 100% federal grants for development of exchanges. We're looking to finalize a rule soon that's going to provide 90% federal match for Medicaid eligibility systems. Recognizing that we have a unique opportunity and a point in time here in which to really invest in these assets. It also increases our responsibility to make sure that those dollars are not wasted and to make sure that we are as efficient and as thoughtful and as urgent as we need to be in getting what we need to get to from a business perspective and making the right use of the funding dollars and approaches. So, okay.
Thank you very much for a tremendous amount of content here, and I think right on spot on the money for what we're talking about here. Well, we have some time to take some questions, and then we'll have, after the lunch break, we have time set up to really also go into some of the more detailed conversations we want to have based on this presentation here. So why don't you, do we need a microphone? Do you guys have a microphone there? So we can capture this, so just pass the microphone. Ivan has it back, and then we'll get it up to here. Why don't you direct it to folks up here? No. Turn on the bottom.
This is from Penny, and the question I have, probably more of a challenge. Since 2014 is almost tomorrow, we at the state have a lot to do to accommodate things. One of the things I would like to suggest is that we want to do less work, not more. So I'd like to suggest that we don't actually build, we use the cloud, but we don't build any portals or interfaces. What we do instead is we publish standards, let the vendors write the interfaces, let them be innovative. It saves us time and money. If we have to do everything, we don't have a lot of resources. We're not going to do as good a job as if a vendor does it. If for example, in Illinois, we have an online application for our All Kids. We provide community organizations $50 for a completed application to incent them to do it. And we've had a lot of success. If we could do that with vendors in many different ways, we could probably not just get a web application for a standard browser, but all the different types of tablets coming into smartphones. We wouldn't have to worry about that because the vendors would have an incentive. It would save us time and money. We would need to certify things. But I think that's maybe another way of thinking about things when we have the cloud. Get us to work on our core business, which really is going to be the back end, making sure we've got the data, making sure people are getting served. But why should we get involved in, in some of these front-end services that many other people in the private sector will do a much better job than we will?
I'm not exactly sure why you're thinking that I'm saying that the private sector isn't doing that.
Part of it maybe is just my conversations previous to this. I'm just assuming something that maybe is wrong.
Yeah, I mean, I think that what the model that you're describing, which I think is a very fruitful one, is kind of the product model, right? It's sort of similar to the fact that for electronic health records, we didn't develop an electronic health record, right? We said, this is what an electronic health record has to do. And then vendors can go out there and meet those requirements, and then they can sell those services, right? So, I mean, the place where I think it slightly breaks down in terms of exactly exporting that model is the place, the client buying the product is the state, right? So it's not like an electronic health record where the government is saying you have to meet certain standards, and then you go off and sell it to providers. In this case, we're all the client. But I do think that sort of standardizing and inviting productization is really important to success, because I think that we need a way for, again, when I talked about expanding competitiveness, I think it's about getting different kinds of vendors, small and large, garage bands, as well as big integrators involved in our business and caring about it, and being able to produce and create the products that are necessary for us to use. And, ultimately, you can take that product, it can be like an app store. I can take that product and I can download it into my environment, or I can decide to leave it there and access it, in the cloud. So it doesn't necessarily mean you have to do it one way or the other. But I totally agree with your concept that we need to be engaging the industry and challenging them to create the kinds of services and products that we need in order to support this activity.
Yes, my name is George Mitchell. And again, my question is for you, Penny. And I guess it's right along the same lines. So the states are going to be allocated a certain pot of money from the federal government. And I guess the question is, what exactly are they expected to accomplish with that particular pot of money? Are they expected to go from start to finish with their exchanges, or what exactly can we expect? I think because since we know that money is tight.
So the way that the exchange funding works is that the Act established grant authority. So the amount of money that states receive will be based upon a negotiation between the states and the federal government through cooperative agreements to support your development activities. So all states have already, well, with the exception of one, received a planning grant. So it was an initial amount of money for states just to begin to get some staff or some consultants to kind of, get their arms around what are these things called exchanges, and do I want to have one or do I not want to have one? And beginning to look at their current assets. So, if I wanted to do an exchange, what would I use? What would I have already available to me? We also then awarded a set of IT innovator grants. These were states that came in under a grant announcement and said, we have governance, design strategies, assets, other things already in place to begin to move quickly, to begin to implement some new technologies in support of our exchanges, particularly from an eligibility and enrollment standpoint and from a plan management standpoint, were kind of the two business functions that we thought from an exchange perspective you needed to start working on sooner rather than later. So what we're expecting is that those IT innovator grants will actually produce assets for use by the larger community of states that are looking to implement exchanges. And that, in point of fact, it may also be true that a state that's not part of the early innovators will also have assets that might be useful to share. And we'll be developing a development environment in the cloud for states and their vendors to use as they start to create some of these assets so that other people can go look at and grab hold of both the artifacts of development as well as some of the products and assets. So when you say you'll get a pot of money and how much will you do, how much you'll do will be in part based upon what you currently already have in place and your thoughts about how much of that can be harvested and reused. Some of that will be based upon what's also in play and available from other states that you might say, I don't think I'll have to do that because I think the state of X is devising a solution and making good progress, and I intend to make use of their particular asset in terms of my overall development. The 90-10 rule that we issued that we'll be final with soon is really a reflection of the fact that of two things. One is that because what I just, when I said it, close your eyes and it's 2014 and you get a determination and it's Medicaid, CHIP, or the exchange, all of you who are experts in cost allocation will immediately recognize that means allocating the costs of those services and systems to Medicaid, CHIP, and the exchange because they all are benefiting from right? The shared service that's essentially creating that determination. So one is because the exchanges get 100% federal funding, we didn't want Medicaid to be too far off of that. And we wanted Medicaid to be able to pull its fair share. The second is that we also recognize that states might want to also improve and modernize their eligibility processes for people whose eligibility is not determined on the basis of income, of which there are still some categories of people that would fall into that category, and we wanted to support that modernization activity.
Question. For those of us that have worked in the States or are working in the States and are familiar with the spaghetti of systems and rules and funding sources and all that, it seems like the last year or even 6 months that we've reached a tipping point. At least I'm really encouraged by your comments. Have we emerged from the dream into reality? Are we confronting the spaghetti? Or are we still at the edge of the dream?
I'm hopeful that we're confronting it. I mean, for many years I think a typical approach, and this is what I've spent time in the private sector as a vendor delivering services to states and to the federal government, as well as being on the government side of that equation. And it seems like we've had a calculus that said, well, because of issues of risk and somewhat because of cost, we're going to continue to keep those systems going because we don't think we have a way out of them. I'm not sure that that's still true, that we don't have a way out of them. And I think that we can be imaginative, though Jessica says that we as feds can't be imaginative, but I think we can. I think together we can be very imaginative.
The more time I spend with Penny, the more I think maybe I could get an imagination.
That we can find our way to eventually get to sunset some of those systems and capabilities. I mean, I think that the ACA really is a game changer in that, from an eligibility standpoint, for example, part of why we've had these complex eligibility systems is because we had complex rules, right? And then you added all of us up, and it's like complex times 4, right? If we can get to this simplified environment where we're really talking about fairly straightforward business rules that, by the way, are available in a repository, and any of your advocates or beneficiaries can look at the business rules and understand exactly how the adjudication decision is arrived at. Okay? That's a requirement. Because guess what? If we can't describe them, then we don't know how our systems and programs work. So those business rules in a place where we can say, this is how the system operates. And then if we could get to the point where we could start to take that kind of an approach and expand it to all of our programs and create that kind of simplification, I think then we can use this train to drive a lot of positive change.
Let me just add to that, if I could, that I agree with that. I think we're there, but I don't think it's a foregone conclusion that we will stay there indefinitely. And that's why I think the moment is so important. I think, the reason why so many states are still using 1970s technology to support these programs is not because they want to particularly. It's part of it is, of course, the pace of technological change was slower than it is now. But a big part of it is the political and the budgetary will hasn't been there to make the investments to change. I mean, many of us, when I was in New York, we constantly bemoaned the fact that technology limited our ability to move in the directions we wanted to go. But there's no way we were ever going to go to the legislature and say, give us the $200 million it would take to move from the legacy system to something else. Now we have both the mandate, the federal statutory mandate, and the funding stream to do it. But those may not stay around forever. So that's why we all think this is such an important opportunity to capture now.
Let's take a couple more questions before lunch, although we can stay in and talk through lunch if we want as well. That's great. Question over here. Go ahead, Bill.
Yeah, Bill Hazel from Virginia. 2 questions quickly. Has there been any thought to trying to simplify the rules under Medicaid from the old eligible, the newly eligible?
Yes, absolutely.
Are you limited by the statute, or
no.
Can you all? Okay, thank you, because that's a big thing for us. If we could figure that out sooner rather than later. And the second thing is more intra-silo issue we have MIDA already looking at it, and we've created data standards for the health information exchange. And the question is how closely are you all following in the social services the health information exchange? Because those are already out there as a marker. And as we look at the authentication pieces and we look at the data standards, it would seem that they should flow from. There shouldn't be an issue of close. It should be.
Yeah, that's exactly what we're trying to do. CMS is way ahead of us on this, and we're trying as much as we can to model what we're doing on what they're doing. MIDA is, in many ways, the model for what we're trying to do in terms of human services information architecture, to establish a set of standards, and then try to, build off those standards. And we want those standards to be as closely aligned with the Medicaid standards as possible and the exchange standards as they roll out. So that's where we hope to go. It's not easy to do that because there's a set of very ambitious mandates that have to be met, and we're talking about doing some additional things that make a lot of sense but are more discretionary. And that's why, but we're trying to make sure that we as much as possible, we at the federal level, and we encourage the states at the state level to do these things in parallel so that one builds on the other.
And I would just say that the unimaginative SNAP people probably have as much challenge here as anything else, because a lot of our rules and regulations are very complex. We're very well aware of that. We have talked before about how really for, 30 years plus, we have all said, well, if we could just get all these programs to have the same rules. And that's not going to happen. And that is why I think this notion that I am getting very excited about the cloud that can have the common information that we can share, and that it can actually directly talk to these various other rules engines, instead of trying to build a rules engine that is the size of all of Yale. To instead let the cloud be Yale and let it talk to and you guys are laughing. It's the only way I can think of talking about it is how I can see it. And you actually have to kind of compartmentalize, and that can actually simplify this, I think, in extraordinary ways, and have us stop spinning wheels on things we can't fix and start fixing the things we can. And I think that's where a lot of opportunity comes for us in these kinds of options that they're talking about.
May I follow? Yeah, just
sure.
Very quickly, the issue is I agree Yale's in the clouds, but the question, though, and what I'm more concerned about in the eligibility, clearly we're going to have different rules. We can work with that. But having the data sets that go in be similar to make it easier on the
Absolutely.
customer. The question is if we can build them broadly enough that we can then do case management between agencies.
Right.
What we struggle with is the fact that we got agencies that can't talk to each other and allowing us to treat it like a medical record and work across is where we want to go. And so it's really the data standards more than the rules engines.
Well, and that's one of the things that actually the HIC committee, the steering committee, looked at was they looked at where they called it harmonization across the various, and it's got to do with definitions and all sorts of things that would empower that a lot better.
I want to also point out that tomorrow we're going to spend a lot more time in the afternoon really talking about the human services interoperability architecture and some of the details around NEAM and what's happening on that. So we'll have a good opportunity to sort of dive into that and the implications of it and trying to harmonize what's going on, what we're hearing today. Last comment on Sandeep?
Yeah, I think the ground reality, though, is that what I have seen in the last 1 year seems to me that Medicaid and health is, instead of getting closer to human services, is getting further apart. Just the fact that it's called, and the rules around MAGI, and it's called insurance, I had hoped that it would have been called a benefit exchange rather than an insurance exchange. And then I think I heard today that these exchanges could do health, human services eligibility too. Is that true that we could get funding through this 100% dollars also for So I think if that's not true, the point is that these two programs, I believe, will go further apart than come closer together, even though we may have had some synergy talks among the agency heads. The ground reality is with the budget cuts at the state level and the resources, we just have to do what is absolutely necessary to get done for 2014, which will probably be a brand new Medicaid system which doesn't interface with the human services side, and then talk about trying to develop interoperability and a platform for later use. However, I do believe that funds will run out to get this whole thing done. That's my fear, that we are moving further away than closer.
And I think we share that concern, and that's why I think what Mr. Virginia was saying is really
Mr.
important.
Virginia, Bill. You're now Miss Virginia.
I think that's why that's so important, and why interoperability has to be looked at as something more than the technology itself. It's got to be the full package. It's got to have that family as being what you're looking at. And what's happening in the Affordable Care Act, from the way I see it, is it's empowering all of us to do things that we haven't done before in terms of how we view that family. And where the systems that they can fund at in a particular way, if you can just think of it as not being restricted when you're building it, I think that's the key in my mind. And it's got to do with that imagination that I don't have that Penny has, so maybe I should stop talking. But I think actually, if we limit ourselves in this way and start detaching, we will not be doing exactly what we say we want to do, which is build an entire service system for a family in need.
So I'll just make a couple of comments. I can understand why it might look or feel that way. But let me tell you what I think we're trying to do that challenges that statement. So one is, in our 90-10 rule, in order for states to receive enhanced match for the development of eligibility systems for Medicaid, states must meet a series of standards and conditions. One of those standards and conditions is that they must provide seamlessness with the exchange and allow for interoperability with other state health and human services programs. So it doesn't say that in order to receive the enhanced funding that you have to have the same kind of architectural business relationship with every health and human services program in the state as you do with the exchanges, because the reality is that in order for the health insurance eligibility determination to work, Medicaid, CHIP, and the exchange all have to be in it together. It can't work apart. But we are emphasizing the desire for the approach to be taken to allow for that interoperability. The second is that we require all of those systems to comply with any recommendations adopted by the Secretary pursuant to the committee established under Section 1561 of the Act, which is the committee that's working on standards and protocols for the exchange of information among state health and human services programs. And the third, so very eager back there in the back, we'll get to you. And the third point is that the approach that we want to take to, again, standardize business processes, nomenclatures, definitions, and ways of messaging will, in fact, continue to accelerate the work that all of you in this room have been engaged on in terms of making it easier for systems and programs to talk to one another.
And one more question, Penny.
We've got to let her.
About the MAGI.
Yeah.
I mean, what's the concern about the timeliness of that data? Because, most of the IRS is, at least a year old. So
for everybody in the room's benefit, MAGI or MAGI or MAGI, that's another one of those acronyms we can't figure out exactly how to pronounce. It turns out the IRS doesn't use the word MAGI. They say AGI. So we had to get that straight very early on. Anyway, that the income standard across the country for exchanges and for Medicaid and CHIP is modified adjusted gross income, which is a tax term. It's really an income standard that exists in the tax code. And when you go to apply in 2014, the data that would be available from your prior year's tax return is going to be 2012 tax return data. So the statute does provide for ways of dealing with that. It talks about changes in circumstances, and we can think of that as being true upon enrollment as well as throughout the enrollment year. That will be a significant part of our policy, first initial policy regulation, which we are targeting for late spring.
Let me just add on this that I think you have put your finger on certainly and from the perspective of interoperability, perhaps the critical decision the states are going to have to make, and not in the next 3 years, in a matter of a few months, as they decide what direction they're moving. And you're right. I mean, there are clearly restrictions on what the funding can be used for. This is the Affordable Care Act. It's about health insurance. And so that it isn't unlimited funding that can be used for supporting any health or human services technology application. It's for health insurance. But in a world of service-oriented architecture and XML and a whole range of other things that I don't understand, it's not as simple as just saying we can use it to build this system but not that system, because the platforms can be used to support multiple eligibility processes and multiple enrollment processes. So I think the question is, in an environment where you're absolutely right, where states are very limited in their ability to put their own money into this and are looking to what Penny can offer them to build out what they have to do by 2014, how creative can states be about using the resources that we're making available to them to design systems that do more than just what they absolutely have to do to meet ACA mandates? And I think that is the critical question, and I hope it's one that there'll be a lot of discussion on over the next couple of days.
And I want to...
Right.
No,
this
lady's been very patient.
We're dying to know what her question
is. Go for it.
That's me. Okay, so I want to build on Dr. Virginia's question, because I've been trying to figure out here whether you're talking about the rules engines and all the rules being in the cloud, or whether states will be allowed to have the client information in the cloud available to other agencies, so that we might have a repository, I think as someone called it, eventually, where the states can share the data, demographic information, perhaps service plans around families, and all the other stuff is just the way you described it. That's in the cloud, but also the person information is in the cloud and unified across agencies. That's what I'm trying to figure out, whether you can do under what you were talking about, Penny.
It's possible, and I could see why it might be desirable. The caution that I would give you is the ability to access certain data created out of certain systems. So it goes back to what we talk about, the issues of privacy, confidentiality. There are some limitations on who can use what data under what circumstances. So, you can't always say, well, somebody came into the state, one part of the state, under a certain legal authority or program and gave consent and supplied data under that construct, and now that data is available to anybody in the state who wants to access it, right? We know that's not true. So understanding that with just that caveat, and in the health system, I'll just say, we are using IRS data. IRS data has a lot of rules associated with it in terms of who can use some of that information and for what purposes. There are also specific statutory provisions about the use of other data that's coming from DHS, and it's use only for the purposes of making a determination under the exchange. So there are, again, people appreciate that there are limits to how data can be used and how it can be distributed. But certainly, and I think this is, what we're talking about here in terms of saying what Bill's point was the electronic case file. To the extent such a thing can be created, appreciating all those restrictions around the use of data and who can see what and all of that, we all know that we have to live with those. That would absolutely seem like the kind of thing that states should be thinking about in order to try to actualize some of this interoperability that we're talking about.
That's great. So all I was worried about is that these, that when the rules get made, that they don't make that very difficult to do. Because I think that it is possible to do what you just said, acknowledging all the health, the confidentiality and privacy and all of that. And so I'm just concerned that we don't, in the rules that we're making now, make that very difficult for states to do when they can do it.
Yes, and I think that issue, when you look at architecture, one of the things that I think is more of a, I mean, all these issues, all these questions come soon, if you look at the kind of timeline that we're working on, right? But what you're really talking about is the persistence of the data. So if I supply data, does it persist in some way inside of the environment? And then if it persists, versus you supply to me, I make a determination, and then that data goes away, right? And there may be some data that, because of its nature, we don't want to make persistent within that system. And then the question of who can then access whatever has been, subject to that kind of persistence rule within that environment, I think is what you're asking.
So, taking my legal authority, I want to give Bill the last word here, and then we're going to break for lunch.
Tagging on in some strategies here with what CMS is doing. If you think of it in the context of 25 to 30 new states, governors with new people coming on board right now, and you do have a number of model programs in the ACF in the Children and Family Services in different parts of the country. But I think to some extent, in addition to the work, and by the way, I'm not presuming this isn't happening, I'm just commenting on this. In addition to the work you're all doing trying to think of in coordinating your approaches, I think it probably makes sense to do a very tight vetting of the states right now, not simply from the point of view of where there are innovative programs, for instance, in children, but where do those occur that might match up with the leadership that's occurring on the health side? Because Sandeep's got a great point. If you don't have in other words, you need to know where the leadership is on the health side in the state as it's driving towards the health insurance exchange and all the other themes out there around ARA. But at the same time, you need to know, okay, so in those states where that leadership exists, where do we have the similar leadership on the social services side? Mm-hmm. Because if you don't match the two of them, they're not going to be able to connect the dots in a time frame that matters. I mean, and the other point I finally on this would add, organizationally in some instances, it'll be easier to do that. So, for instance, Bill Hazel has all of those programs under him. So that if he's looking at children, Medicaid and what he wants to do in the health, he's thinking of Medicaid eligibility, but he's also thinking, what's that mean regarding TANF children? I've got to rebuild those systems later anyway.
That's why he's called Mr. Virginia.
I think it's a vetting right now of the leadership in those states. First on the health, and then in the social services.